Hello everyone, welcome to the section of cardiology, the study of the heart. This is Dr. Jaitly. In this video vignette, I'll be talking to you very briefly about why treat pulmonary hypertension, which is a very often unrecognized condition. Now, first let's dwell on the fact that what is pulmonary hypertension? Well, just like we have a blood pressure, which is systemic blood pressure, and that should be normally 120/80, which is normally measured in the arms. Similarly, in all arterial bed and venous bed and capillary beds, like we talked about, look at this left upper panel, there is a pulse pressure, and the arterial bed carries a higher pressure than the capillary bed, than the venous bed, because by then the pulse as well as the pressure head declines, and then it arrives into the right side of the heart, as we know. So similarly, just like we have 120/80 in a normal systemic blood pressure, the pulmonary arterial bed will carry a pressure which is roughly 25/10 millimeters in mercury. Everything is millimeters mercury. So anything over that, by definition, is pulmonary hypertension. So having defined that, now let's understand what are the causes of pulmonary hypertension. Well, the primary causes, I'll try to enumerate quickly. Again, this is not an exhaustive list, but I recommend that should you have to supplement through medical journals, articles, textbooks, etc., please feel free and do so, because that's going to give you the full exhaustive list of pulmonary hypertension. However, within the scope of this quick video vignette, I've tried to highlight some of the important ones. Primary pulmonary hypertension is present with or without congenital heart disease. Intra-cardiac shunts are specifically noted to cause pulmonary hypertension, namely the Asst and the Vst. Look at this lower right panel, and here I've tried to show you the Asst, for instance. That's a diastolic murmur which occurs when the shunt is across the left atrium to right atrium. Now, this is an abnormal aperture that's present at birth. This is Vsd, where there is a ventricular septal defect. That was an atrial septal defect. This is ventricular septal defect. Again, the shunt is between the left and the right, and this is a systolic murmur producing condition, which again manifests as pulmonary hypertension at a later time. So Asst and Vst are the commonest intracardiac shunts you should be aware of in congenital heart disease when there is a pulmonary hypertension present. Now, primary pulmonary hypertension, where there is no cause, that's idiopathic variety, where the pulmonary arterial bed itself, like in this panel, for instance, will have documented pressures over 25/10. Secondary pulmonary hypertension, which is the more common variety, which we commonly see day in and day out in our clinical practices, well, that encompasses valvular heart disease, which is a major component, and out of which mitral and aortic valve disease is the commonest variety. So you can have mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. Heart failure, which is an ever-increasing epidemic in the past few decades, we have seen, because people are living longer, and as I always mention, we're going to die of ailing and failing hearts. That's why heart failure is an increasing epidemic, and unfortunately is also accompanied by pulmonary hypertension, which should be recognized. And we'll decide to treat that at a later time when we dwell on those facts at a later time in my next video vignette. Lung parenchymal disease, for instance, the COPD, the interstitial, and sarcoid, excuse me, will have a similar presentations, because the resistance through the pulmonary venous areas, this is the pulmonary veins, will be increased, and as a result, the arterial bed and the capillary bed will eventually have a transmission of that higher pressure across the system. And similarly, mitral stenosis, mitral regurgitation normally causes pulmonary venous pressures elevations first, and then there will be pulmonary arterial hypertension as well. So just remember that pulmonary veins pressures can rise, and so can the capillary pressures rise, and therefore the arterial bed pressures will rise. Or you could have peripheral vascular resistance here itself because of a thromboembolic phenomenon in the arterial bed or in the capillaries, which can result into pulmonary hypertension. Sickle cell disease, primarily because there's a lot of hemolysis happening at the capillary levels, hypoxia, induced by sickle cell disease will also result into pulmonary hypertension. Liver cirrhosis with portal hypertension is also a very miscellaneous cause, but should be remembered, and not to forget sarcoidosis, which we see fairly common in our practices. What are the clinical symptoms? Well, the first initial presentation could be very non-specific, where it could be only chronic cough and wheezing, and then effortful shortness of breath. That each time a patient begins to walk, the shortness of breath occurs, and that's called initial effort dyspnea. Later on, the patient is unable to lay in bed and cannot lay flat. That becomes orthopnea, which is related to reclining position, or PND as we call it, paroxysmal nocturnal dyspnea, which is a full form, where the patient is awakened in the middle of the night at 2 a.m., 3 a.m., 4 a.m. That's the classic time when the patient wakes up and is markedly short of breath. That's classically seen in mitral valve disease per se, or in left ventricular failure, like the heart failure patients will present with PND. Mitral stenosis notoriously also presents with hemoptysis, just so that you know, because of the pulmonary venous hypertension and the capillaries bursting within the lung alveoli, and as a result in the morning or early hours patient may cough up blood, and that's called hemoptysis. Now let's quickly dwell on the diagnostic tests which are available. There is a huge armamentarium of tests which you can employ, starting with a basic simple chest x-ray, I call it CXR, an EKG or ECG, and then an echo. The echo will define the right-sided pressures as well as the left-sided pressures for you, and will also define whether there is any cause from the valves per se here, like I've shown in this case, mitral stenosis in the left middle panel, and in the left lower panel, as I said, the aortic stenosis, where the aortic valve is stenosed. So you could have mitral valve disease, aortic valve disease, resulting into pulmonary hypertension that could be easily diagnosable by a simple echo within a few minutes. Pulmonary function tests are really required to diagnose interstitial disease, COPD, for instance, or bronchial asthma, which has not been treated for a long time, obstructive sleep apnea, which is very common in patients who are markedly obese, and then hypoxia that results in patients who move up to high altitudes rather suddenly. Other testings that are available to you are the VQ scans, the CTA or CT chest, the right heart catheterizations requiring to demonstrate the pulmonary wedge pressures to be elevated, and then you have pulmonary angiography, which is rarely done, but it's done in the settings of where you could therapeutically also clear out the thrombus from a thromboembolic phenomenon that may have occurred during the course of the illness. So in a nutshell, pulmonary hypertension is an often unrecognized condition. The above causes, as I mentioned, including lung parenchymal, primary with or without congenital heart disease, and of course thromboembolic phenomena, as I said. And clinical symptoms could be very non-specific initially, but they're all respiratory oriented. Chest pains and syncope are also present in very, very significant cases of pulmonary hypertension. And the diagnostic tests, as I have enumerated, and the conditions, as I mentioned here, between mitral and aortic valve disease, intra-cardiac shunts, and the left ventricular failure, as I've shown in the right upper panel here. Thank you for your attention. Hope you found this interesting, and we'll be discussing more as we go along.